Is an employer-based integrated physical medicine approach effective? Healthcare has become both unnecessarily expensive and complicated, catalyzing a host of new approaches to improve access, decrease cost, and improve outcomes. In the high-tech industry, many of the off-site amenities such as quality food, gym, personal care, etc. are brought to the employee to provide not only convenience but savings in time away from work and potential decrease in cost compared to subsidizing off-site alternatives. The thought was then to extend the strategy to health services, given it has been estimated that as much as 3 hours of work time is lost to travel, wait time, and seeing a healthcare provider, and obtaining drugs and other services. In addition, the cost of that service is largely out of the control of the employer. The average employer pays more than $10,000 per employee per year towards benefits, and much of this is administrative cost. A number of groups have established models for on-site integrated health providers to market to large employers in an effort to better guarantee access to most services, including emergency services, primary care, and commonly sought care such as for musculoskeletal complaints, vision, dentistry, and OBGYN. Some of the most costly healthcare interactions, such as emergency rooms, pharmacies, and out-of-network referrals, etc., can be completely eliminated when employees have easy access to an on-site healthcare provider. The leading cause of short-term or temporary work disability is musculoskeletal pain. Employers not only bear a disproportionate share of these costs, but also suffer from approximately 290 million lost workdays annually. In one study, early access to physical therapy in employee populations was associated with a 36% improvement in patient outcomes, 52% less imaging, 56% fewer spinal injections, 59% less lumbar surgeries, and 62% less opioid use. Although approximately 30% of employers with 5,000 or more employees have on-site clinics, less than 50% of on-site clinics have integrated physical therapy, and very few have comprehensive physical medicine services that include physical therapy, chiropractic, and acupuncture integrated with on-site primary care. So let's review an important new study which compares employer-sponsored care using one of these new models called Crossover Health, comparing outcomes and utilization across similar services. The title is Integrated Physical Medicine in Employer-Sponsored Health Clinics Improves Quality of Care at Reduced Cost. This was published in the Journal of Occupational and Environmental Medicine in 2019. The study focuses on several hypotheses related to the crossover model. In other words, the belief is that this integrated model will increase access to physical medicine services, result in equivalent or greater improvements in pain and functional status outcomes, decrease opioid use, improve patient experience, and decrease total costs of care compared with similar patients cared for in the community. The ability to access and compare outcomes for this study was based on FOTO, Focus on Therapeutic Outcomes. FOTO has the largest available dataset on outpatient physical medicine outcomes in the United States. FOTO uses an intake functional status score to assess baseline functional status using multiple functional measures. For example, FOTO assesses functional status among patients with low back pain with computerized adapted versions of the Oswestry Disability Index and Fear Avoidance Belief Questionnaire, among others. In this study, patients completed the FABQ, which measures the extent to which a person suffering from musculoskeletal pain avoids physical activity because they fear that such activity will exacerbate their condition. On the photo-adapted version of the FABQ, scores of less than 44 suggest low pain fear avoidance, and those 44 or higher suggest high pain fear avoidance. FABQ scores are predictive of workplace disability, especially for employees with low back pain. Also in the crossover model, those with high FABQ scores are evaluated with a Patient Health Questionnaire 9 that screens for psychological factors and depression, and with on-site psychological services allows on-site referral and co-management. The study was a retrospective study evaluating all patients with musculoskeletal complaints seen in crossover health integrated physical medicine departments at 12 employer-sponsored clinics in the United States between December 2016 and March 2018. The researchers compared data for crossover patients to two control groups. Control group 1 was used to compare clinical outcomes. They compared patients receiving physical medicine care in the employer-sponsored crossover clinic to matched controls in the FOTO database. The clinical outcomes included functional status and the FABQ. And for utilization, they were compared to control group 2, who were community-matched controls. These were based on aggregated healthcare claims across multiple employers in multiple geographies to assess healthcare utilization for provider visits in the community, imaging, surgery, spinal injections, and opioid use. Examining baseline functional status for clinical characteristics of the 2,493 unique patients, they found that 56% were male with a mean age of 38.5 years. The intake functional status score was 60.5 out of 100. FABQ scores at baseline were 47.5, where FABQ scores at least of 44 suggest high pain fear avoidance. Neck and lumbar spine complaints accounted for 54.7% of all cases. The following characteristics were significantly associated with worse functional status at baseline: older age, female gender, history of prior surgeries, an exercise regimen of less than once or twice a week, and medication use. The results indicated that the functional differences between employer-sponsored clinics and FOTO controls was 3.8 for spine patients and 3.6 for neck patients. The average pain fear avoidance for all patients seen by physical medicine providers decreased significantly from 47.5 to 40.2. Similar significant improvements were found for lumbar and neck pain patients. For lumbar pain, FABQ scores improved from 49.4 to 40.9. Neck pain patients' FABQ scores improved from 44.6 to 39.5. And from the FOTO analysis, patients with neck and spine pain were seen on average 6 fewer visits than controls. Employers saved $472 per patient with these conditions. Specifically, patients with spinal pain seen in employer-sponsored clinics required 5.7 fewer visits to restore their physical function compared to FOTO control patients. Similarly, patients with neck pain cared for in an employer-sponsored clinic required 6.3 fewer days compared to FOTO controls to achieve resolution of their symptoms. And it turns out that more providers are better than one. Neck pain patients who were seen by more than one type of physical medicine provider achieved better functional status with a mean functional status increase of 6.8 compared to patients seen by one type of provider whose mean increase was 2.8, all without an increase in total number of physical medicine visits. Patients with lumbar spine pain treated by more than one physical medicine provider type achieved resolution of symptoms in fewer visits than those seen only by one provider type. Regarding opioid use, opioid prescriptions were approximately 2.8% in employer-sponsored clinics, with 1.3% of patients cared for by physical medicine, compared to the U.S. average of 20%. The vast majority, 70.3% of opioid prescriptions in the employer-sponsored clinics, were for cough suppressants. Cost was tied to utilization related to outcomes. The mean number of visits in the community cohort was 11.9 versus 3.9 visits in the employer-sponsored clinic. So, given patients seen in employer-sponsored clinics required an average of 8 fewer visits, employers saved $630 per patient episode overall. Provider mix at crossover is key to predicting utilization. Primary care staff include registered nurse practitioners and physicians, including MDs and DOs, with specialization in family medicine, internal medicine, and emergency medicine. Behavioral health staff include psychologists, social workers, and psychiatrists. Physical medicine staff include chiropractors, physical therapists, and acupuncturists. Additional clinical staff include dietitians, optometrists, massage therapists, health coaches, and nurses. This provider mix enables both interdepartmental referral and intradepartmental referral within physical medicine. Design of the clinics is crucial where structure facilitates function. Specialties are not segregated in the bullpen central provider environment, facilitating interaction and cooperation. For physical medicine utilization, physical medicine was the second most utilized service in the integrated employer-sponsored clinic at 42.9%. 21.2% seen in the employer-sponsored clinic received physical medicine services without any other type of care, and these were self-referred directly into the physical medicine services department. Across all physical medicine practitioners, there are approximately equal proportions of physical therapists and chiropractors, about 40% each of the total physical medicine staff, and approximately 20% are acupuncturists. Most patients receive care by either a chiropractor, 35.4%, or a physical therapist, 29.9%. So let's look at the integrative model designed and utilized by crossover services provided in physical medicine. Therapeutic modalities included directional preference exercises, manual and instrument-assisted soft tissue therapies, manipulation and mobilization, and education on ergonomic strategies with a focus on exercise rehabilitation. In summary, the crossover design and approach demonstrated ease of access to providers. The outcomes were significantly improved when patients saw more than one physical medicine provider. With a reduction in number of visits for an episode, there were savings not only in cost, but days that may affect work-related function. Most importantly, this study demonstrates that when using a large national data set, it's possible to compare effectiveness in different settings. And within the same settings, such as the 12 crossover facilities, it is now feasible to conduct best practices research to determine if there are more effective approaches for any given condition at any given site. Then, by determining what is different but effective, all may advance. And a final note, most of the chiropractors in the crossover staff are graduates of Palmer College of Chiropractic West.